Welcome to the Paediatric Trauma Resuscitation Course, in association with the Paediatric Blast Injury Partnership and supported by the University of the West of England. Our mission is to increase the knowledge, skills, and confidence of healthcare professionals managing paediatric trauma. The Paediatric Blast Injury Field Manual will take you through the vital steps required to look after any severely injured child from the moment of injury all the way through to providing psychosocial support during their recovery. This film will provide insight into the team approach to the initial resuscitation phase of a severely injured child arriving into hospital.
Hello, emergency red phone. We've got a pre-alert for paediatric trauma. Go ahead.
When giving a pre-alert, it's important to deliver the information in a structured manner. This ensures the hospital trauma team know as much relevant information as possible about the patient arriving. To achieve this, we use the ATMIS structure, which stands for age, time of injury, mechanism of injury, injuries identified so far, signs and symptoms of the patient, such as the heart rate and respiratory rate, and treatments given so far or about to be given. The trauma team can use this information to prepare themselves for the patient they are about to receive.
Okay, so you've got, for age, you've got a 7-year-old boy, time 15 minutes ago, and the mechanism was a bus explosion. His injuries are a deformed femur, bruising to his abdomen, and a scalp laceration. He's agitated, he's tachypneic, he's tachycardic, and he's got a low GCS. And the treatments that you've given is some oxygen. Okay, how long are you going to be? 10 minutes. All right, we'll see you in recess.
Based on the pre-hospital information, I'm extremely concerned that this child may have significant injuries. I'm immediately considering the mechanism of injury, which is high energy, and unusually may include primary blast injury. I'm considering the type of injuries he may have and the people and resources I may need to manage them. It's essential to prepare yourself, your team, and your environment.
Morning everyone, thanks for coming down to ED. We've got a trauma case coming in, so we'll do some introductions and sort out the roles. So my name's Becky, I'm the trauma team leader today. Bridget, do you want to start?
My name's Bridget, I'm one of the ED nurses.
Great, thanks Bridget.
My name's Abby, I'm one of the paediatric surgeons.
Great, thanks Abby. Are you okay to do hemorrhage control today?
Yeah, sure.
I'm Tom, I'm one of the ED doctors.
Great, Tom, could you do IV access for us?
Yeah, that's fine.
I'm Gavin, I'm one of the ICU doctors, I can be airway assistant.
Lovely, thank you.
Hi everyone, I'm John, I'm one of the resus team paramedics.
I'm Anthony, I'm one of the anaesthetists and I'm happy to do airway.
I'm Warren, I'm one of the other surgical doctors.
Great, could you be a scribe for us today, please?
Of course, no problem.
Lovely, thanks.
I'm Chris, I'm one of the ED nurses. I'll do drugs and fluids today. I'll get an age per page ready for a 7-year-old and I'll get a wet bag.
Okay, lovely.
I'm Liz, I'm a paediatric emergency doctor. I can do the primary survey.
Okay, brilliant. Thanks everyone.
Children vary greatly in size and weight. We must be sure we are going to have all the correct doses for drugs and other treatments either ready or at least written down clearly so that we don't have to calculate them in a hurry once the child arrives. To help with this, we often use an age per page resource, or we can write out a wet bag, which uses the child's age to make approximate calculations on a variety of important interventions. Weight. Whilst it is essential to obtain a correct and accurate weight once the child is stable, we can gain a safe estimation for emergency use by using the calculation of age plus 4 times 2. So in this case, we would use 7 plus 4 times 2 equals 22 kilograms. Tube size. Diameter can be calculated by age divided by 4 plus 3.5 for a cuffed tube, and it is advisable to have a tube one size smaller available just in case. Cuffed ET tubes should be used irrespective of age, as they provide better ventilation and help us to prevent aspiration. In this instance, we would probably want a 5 and a 5.5 endotracheal tube available. The length of the tube at the teeth can be worked out as age divided by 2 plus 12. So for our child, this would be a 15.5 centimetre depth to hopefully ensure we do not push the tube too far in. Tranexamic acid dose. Tranexamic acid helps to improve the clotting and has been shown in large-scale trials to reduce mortality in major hemorrhage in a time-dependent manner. The quicker the dose is given, the better. The dose is 15 milligrams per kilogram as an initial bolus, so the estimated dose for the child coming in is 330 milligrams. This will be followed by an infusion. Blood products or fluid boluses. We use 5 ml per kilogram boluses for blood products and any fluid boluses. This is roughly the equivalent of a unit for a 70 kilogram adult. This allows us to track the transfusion safely and not to over-transfuse. We need to monitor for hyperkalemia and hypocalcemia and treat if necessary. Antibiotic dose. This depends on which antibiotic is available and the mechanism of injury. For example, if we use comoxiclav, we would go for a dose of 30 milligrams per kilogram. In this case, the dose would be 660 milligrams. Glucose. This is calculated as 2 mils per kilogram of a 10% glucose. So will be 44 mils for this child if a hypoglycemic event occurs.
Okay everyone, we've got some more information from the pre-hospital crew. So they've given us an at-mist. So we know that this is a 7-year-old male who 15 minutes ago was injured in an explosion on a bus. The injuries that have been identified so far are an occipital scalp wound, a deformed femur, bruising to the abdomen. He's tachycardic, he's tachypneic, and he has a decreased GCS with some agitation, and the treatment that's been given so far is oxygen only. So I'm concerned that this might be a primary blast injury. That's not something that we see very often, but I want us to think of that as we go through the assessment. So that will particularly affect his lungs and his GI tract, and he may well have a traumatic brain injury as well. And the reason I'm thinking of that is because of his low GCS. So there's a few things that we need to get ready before he arrives. So Tom, would you be able to put the major hemorrhage call out for us, please, to switchboard?
Yeah, I'll do that now.
Brilliant, thank you. Bridget, can you let CT know that we might need an urgent CT when he arrives?
Yes, I'll do that.
Brilliant. And Abby, could you let theatres know that we might need to come up to...
Yeah, sure, will do.
Brilliant, thanks guys.
I want to make sure that the team are briefed thoroughly but quickly with the information that we have. This means we can all start working together with a shared mental model of not only the potential injuries likely to be present, but also the interventions that might be immediately necessary and the possible pathways to definitive care once stabilised.
Hello guys.
Hi.
My name's Abby, I'm one of the paramedics,
Hi, Abby.
and this is Lottie, and I've got James as well, these are my colleagues.
Hi guys, my name's Becky, I'm one of the trauma team leaders. Before we do handover, can I just do a couple of checks? So can we confirm that he has a pulse?
He does have a pulse, yeah.
Great. And is there any catastrophic hemorrhage?
Not that we've observed, no.
Lovely. And is his airway patent?
It is, yes.
Lovely. Okay, so let's go on to handover.
So I'm now going to give my at-mist. So we've got a 7-year-old male called Seb. 15 minutes ago, he was involved in an explosion on a bus. He was removed from the scene by the fire crew and has been subsequently treated by ourselves. In terms of our injuries, we have got an occipital laceration, bruising to the abdomen, and we've also got deformity to the left femur. In terms of our signs, he's GCS 9, so that's E2, V2, M5. We've observed him to be quite agitated, and due to this we've struggled to get observations, but we have observed him to be tachypneic and tachycardic. In terms of our treatment, he has been given oxygen through a non-rebreather mask, and he's also been given a dressing for his laceration. He's struggled to keep the oxygen mask on because he keeps pulling it off, but we'll try to keep it on as much as we can. In terms of an ample history, he has got no allergies, he has got no regular medication that he takes, and his personal medical history, there's nothing of significance. Seb last ate 2 hours ago, and he was fine before the explosion. We're just unsure as to the specific mechanism, aside from the fact that he was involved in the explosion. So that's it from our side, if you've got any questions.
Just one question from me. Do we know anything about the parents?
Mum was with him at the scene. Yeah. I believe she's still being treated by one of our paramedic crews, okay. But she's aware that he is here.
Okay, lovely. Great. Does anyone else have any questions for the crew? No? Okay, thanks guys.
Perfect, thank you.
It is vital to ensure the child is completely uncovered and a thorough check for life-threatening injuries is completed rapidly. We must not miss injuries to the back, but we also do not want to move the patient too much. We therefore do a log roll once to examine the posterior and minimise the degree of patient tilt.
Let's get him over onto the bed. So we're going to log roll him, and at the same time we're going to check his back. So Liz, could you do that for us? So I want us to be really careful with very gentle log roll so that we're minimising any movement, so we don't disrupt any clots that have been made. So Anthony, can I hand over to you to lead the log roll?
Lovely. Okay, so I'm Anthony. I'm one of the anaesthetic doctors here. What we're going to do is roll you over a little bit, have a look at your back and check your back's okay, and then slide you over on a new slide onto a new comfortable bed. So if everyone's happy to set up for a log roll, I'll maintain inline stability. What I'll be saying is ready, steady, roll. We'll be moving on the roll, and that's for all of the commands, okay? We just need to move far enough for Liz to be able to look at the back and for us to get the pat slide under, and we'll hold him in that position. Everyone ready?
Yes.
Okay, so be ready. Ready, steady, roll. Well done.
So there's no sign of penetrating injury to the back or buttocks.
Okay, let's bring in the pat slide, please. Everyone ready?
Yep.
Ready, steady, back. Okay, all hands on and ready to slide across.
Yep.
So we're just going to move you onto your new bed. Ready, steady, slide. And then to get him off, we're just rolling as little as we can to the left. Ready, steady, roll. And see if we can get the slidey sheets out.
We can get it out from this side.
Okay, ready, steady, back.
So let's get the trolley out now and then we'll start our assessment.
James, can I give you that behind? Grab this down 15 litres.
Okay, let's start our C, A, B, C, D, E assessment. So first of all, can we check for any catastrophic hemorrhage? So Abby, do you want to have a look for any hemorrhage and see if we need to control that?
Yeah, sure.
We know we've got a head wound.
So I can't see any significant bleeding from the femur, but there is a lot of bleeding coming from this laceration on the scalp. So I think we should put a haemostatic gauze on, another dressing and some pressure, and that should get control of it.
Okay, great, thank you.
When dealing with trauma cases in resus, we follow a C, A, B, C, D, E structure for the primary survey. At first, we consider C, which stands for catastrophic hemorrhage. This is a circulatory problem. The first thing I am looking for in this role is any potentially catastrophic external hemorrhage that I can stop with direct pressure and then with haemostatic or pressure dressings or a tourniquet. We also need to consider placing a pelvic binder on any child with a suspected pelvic injury or a lower limb amputation to minimise bleeding internally within the pelvic cavity. In older children and adults, scalp wounds are not normally a source of catastrophic hemorrhage, but in smaller kids it can be, and either way, stopping ongoing external bleeding is vital in patients in extremis who have already started to decompensate, as shown by hypotension.
Anthony, could you tell us about A for airway, please?
So he's maintaining his own airway. There's no obvious bleeding into his airway. There's no obvious foreign bodies. He has been fidgeting and putting in his oxygen, but other than that, his airway's fine. When assessing A, the airway, I'm looking for any signs of current or imminent airway obstruction, such as blood or vomit, loose teeth, debris, or signs of possible burns to the airway. If there are any problems, I can use a jaw thrust or airway adjuncts, including an oropharyngeal airway or a supraglottic airway, such as an iGel, to help me keep the airway patent whilst I plan for definitive intervention. This would be with a rapid sequence induction of anaesthesia followed by intubation. When dealing with children's airways, there are certain additional things to consider. Neonates and infants tend to have a more anterior appearing larynx with a floppy epiglottis, meaning a straight blade such as a millilaryngoscope is often required. Their airways are narrower than adults and consequently obstruct rapidly with minimal swelling or foreign bodies. They have softer necks and airway tissues that are easier to compress and occlude with handling or swelling, so it is important to only impress on bony structures during airway manoeuvres. Due to the changing comparative head size as children grow, we may need slightly different head positions in order to maintain an open airway when dealing with an infant as compared to an older child. In trauma, we also must consider C-spine control as part of the airway assessment. We very rarely use neck collars anymore, and particularly in awake patients. If a patient is calm, we can apply blocks and tape to remind the patient to minimise head movements. But if they are agitated or moving a lot, then we may cause more damage if we try to secure the neck in a collar.
Liz, would you be able to assess B for breathing in your primary survey, please?
Sure, so we've got a respiratory rate of 40, SATs at 80% on high flow oxygen. He's got equal air entry both sides and equal chest wall expansion, and I can't see any signs of a pneumothorax to explain the hypoxia.
We know that external signs of injury might not be present in children even if there is significant intrathoracic injury due to their very compliant chest walls. Any rib fractures are a sign of significant force, especially the first and second ribs. The ribs are more horizontal and young children rely more on diaphragmatic breathing. The ribs also provide less protection to the abdominal organs than in adults. Children have a lower functional residual capacity and a higher oxygen consumption than adults, meaning they desaturate much more quickly. We also know that tachypnea is an early sign of injury and hypovolemia, so it's vitally important to recognise. However, it can be missed if we do not take into consideration the changing normal physiological ranges for respiratory rate, pulse, and blood pressure as children age. There are several thoracic injuries such as tension pneumothorax, massive haemothorax, and cardiac tamponade that need to be recognised early and treated, otherwise they will lead to cardiac arrest. Injuries caused by a blast pressure wave, such as blast lung and particularly blast injuries of the bowel, may take several hours to present.
Liz, can you move on to C for circulation, please?
So we're cool peripherally and I can't feel a radial pulse, but the heart rate on the monitor is 170. We've got a central capillary refill time of 6 seconds, and we're doing a blood pressure now.
During the circulation assessment, we are looking for signs of shock such as tachycardia, prolonged capillary refill time, pallor and tachypnea. Children have less ability to increase the stroke volume and rely on tachycardia to maintain cardiac output. Tachycardia in trauma is always due to hypovolemia until proven otherwise. It's therefore imperative to know the varying physiological normal values of heart rate and blood pressure to ensure that circulatory problems are not missed. Children decompensate late and catastrophically, and hypertension is considered a peri-arrest finding. Whilst in adults we may utilise permissive hypertension, tolerating lower blood pressures than normal to avoid busting the clot in trauma resuscitations, there is no such thing as permissive hypertensive resuscitation in paediatric trauma care. Firstly, we need to ensure that we prevent any further hemorrhage by dressing wounds, splinting fractures, and ensuring a pelvic binder is applied if necessary. Secondly, it's vital to rapidly gain access to give fluids, blood, and analgesia, and we should consider intraosseous access as an early or first option in the shocked child to avoid delay. Once access is established, we can use 5 mL per kilo boluses of blood, blood products, fluids to maintain a radial pulse. If blood or blood products are not available within a few minutes, we can use other fluids, such as normal saline, Hartmann's or Plasmolite, but we should never use hypotonic or hyponatremic fluids for resuscitation of a child. In any patient with suspected major hemorrhage, we should ensure tranexamic acid at 15 mg per kilo is given to aid clotting.
So can you assess his abdomen and his pelvis then? Tom, how are you getting on with access?
Yeah, I'm struggling with IV access, so I'm going to put an IO in.
Okay, yeah, that would be great. Yeah. And then we can think about giving him some blood products.
Okay, yeah, we've got the blood available here. Gaining IV access in children can be difficult, particularly when they're in hypovolemic shock. Intraosseous access offers a very effective route to deliver resuscitation fluids and drugs. It is the easiest way to gain vascular access in small, shocked children. The first option is the proximal tibial insertion point, approximately 1 centimetre distal and medial to the tibial tuberosity. This will vary a little with the size of the child. Other possible insertion sites are the proximal humerus, the distal femur and the distal tibia. IO needles require significant pressure to provide fluid and drugs through them, so you will not be able to just hang up a bag on a drip stand, but will have to actively push the fluid, drugs or blood products in. You can do this using a 3-way tap attached to the IO needle to draw up the fluid into a syringe, then turn the 3-way tap to allow you to actively push the fluids through the needle. Rapid transfusion devices can also provide enough pressure to deliver fluids via the intraosseous route.
Okay, so let's do that then, and then we can get some red cells in.
I'll do that now.
Lovely, thank you.
Okay. Okay, IO's in.
So Anthony, would you be able to give us your assessment of D, please?
So GCS seems to be unchanged from when he came in with the paramedics. That's E is 2, V 2, M 5, giving a total of 9. I haven't been able to assess his pupils. Abby, are you happy to have a look?
Yeah, sure. Sab, I'm just going to open your eyes. And the other one, just shining a light. So they're equal and reactive to light.
During the disability assessment, it is vital to ensure we are clear about the level of consciousness. Any change in this may indicate a traumatic brain injury requiring neuroprotective measures. The motor component of the GCS is the most indicative of outcome in patients with head injury. A higher M score is more indicative of better outcomes. Low GCS can lead to airway compromise due to loss of airway reflexes, so might be a reason to intubate early as well. Pupillary response is important to check. Dilated or unresponsive pupils may be suggestive of raised intracranial pressure and a requirement for hypertonic saline administration. Stressed, injured, and hypothermic children are also at higher risk of hypoglycemia. It is essential to check a serum glucose in all children and correct hypoglycemia with 2 mL per kilo of 10% glucose. It is important to consider pain management early in paediatric trauma patients. Pain is often under-recognised in children and poorly treated. Pain therefore needs to be treated early and well. This will ease the child's discomfort and stress and can improve physiological signs like the heart rate. It is also vital for psychosocial recovery. There are multiple ways and routes of providing good analgesia. Intranasal, oral, and intravenous are often used, as are regional anaesthesia techniques and splinting injured limbs. Parental support is paramount.
Bridget, could you get some IV paracetamol and IV morphine drawn up as well? Give the paracetamol straight away. Liz, could you have a look at his abdomen and pelvis to see if there are any injuries there, please?
On examination of the abdomen, then there's a lot of pain and tenderness on the left upper quadrant, so I'm a bit worried about the spleen. The pelvis doesn't look quite symmetrical, but I haven't manipulated it, and there's a deformity in the left femur, so I'm worried about a pelvic fracture possibly and a fractured femur, and I think we need to put a binder on and a splint.
In children, there is less protection for the abdominal organs such as the spleen and liver due to the higher level of the ribs anteriorly. This means the organs are at a greater risk of injury. Fast scanning does not identify solid organ injury and therefore does not have a role in ruling out these types of injuries in children. However, ultrasound scanning may identify fluid in the peritoneum, chest, or pericardium, so can be a useful tool. Never manipulate the pelvis. If a pelvic injury is suspected, apply a pelvic binder. A binder should also be applied in all children with blunt trauma and a low BP for their age.
Bridget, please could you do a temperature?
His temperature is 36.5, so I'm going to turn the heating up and put some more blankets on.
Chris, could you do a blood sugar for us, please?
Yeah, we've got a blood sugar of 6.8 and I've sent up for gas.
Aaron, have you got everything you need to ascribe?
Have we given any tranexamic acid yet?
No, I don't think we have. Thank you, that's a good reminder.
The role of the scribe is vital for maintaining an accurate record of all the findings and interventions performed. In stressful situations, with lots happening at once, it's not possible for the trauma team leader and other team members to precisely remember everything that has happened and at what time. To prevent errors and to ensure nothing is missed, a scribe will therefore document as much as possible, including key interventions, observations, and medication administration.
Okay, thanks everyone. So just to summarise where we are, we have a 7-year-old boy who's been involved in an explosion. His injuries so far are a probable traumatic brain injury, abdominal, pelvis and long bone fractures. The plan for us now is we've got the pelvic binder on. We need to do an RSI to intubate the patient and take him to CT. We'll continue to give blood products as we need and then we'll reassess where we are after the scan. Does that sound okay to everybody?
Yep.
Okay, thanks everyone. Okay, so we're moving towards doing our rapid sequence induction now. So the reasons that we're doing this are that we want to protect his airway. He's very hypoxic and there's a risk of vomiting. So let's go through our checklist and prepare for that. So because he's so unstable, we're going to use fentanyl, rocuronium and ketamine in a 1:1:1 ratio. We'll go through our checklist and then if everybody's happy, we'll proceed. So our first question is preparing for difficulty. Is a difficult airway anticipated?
Yes, it is. This child has a major trauma, inline stability, so we do anticipate a difficult airway.
Okay. And are there any other complications anticipated?
There's a risk of full stomach and vomiting. He's also had a blast injury to his chest, so there may well be pneumothoraces You may have cardiovascular collapse because of hypovolemia.
Okay, so if you were to vomit during the procedure, what would we do?
So we would, to the best of our ability, do a log roll to one side, trying to keep him in line, suction his airway, and then return to supine for me to intubate.
Okay, is everyone else clear with that? Great, okay. And then the final question for the first section is, do we have everybody here that we need? Is there anyone else we'd need in an emergency?
No.
No? Okay, great. The next section is preparing equipment, so we need to check we've applied the correct monitoring, so ECG, blood pressure, SATS probe and capnography. And other equipment, a mask, Goodell airway.
Yes, yes.
T-piece and oxygen supply.
Yep.
Suction.
Yes.
ET tubes in a few sizes.
Yes.
2 laryngoscopes.
Yep.
And equipment for an alternative plan.
Yes, so failing being able to intubate, we'll maintain oxygenation with a supraglotic high gel. If we're unable to do that, we'll have to do a surgical front of neck.
Okay, great, thank you. And a bag valve mask. And then drugs, so we've got an induction agent, an analgesic, muscle relaxant, and do we have any drugs for circulatory support?
We've got additional blood products.
Okay, thank you. And then what will we use for maintenance sedation?
We're not going to be waking this child up immediately, so we'll use a morphine midazolam infusions with the rocuronium, please.
Okay, great. The next section is preparing the patient, so can we confirm that we've got IO access? Is pre-oxygenation optimal?
Yes.
Great. Is the patient's position optimal?
Yes.
Do we need to insert an NG tube beforehand?
Not beforehand. As soon as you've got the tube in, we'll try and do that.
Okay. And is there anything else generally that we could think of to optimise the patient's condition? Okay. And the final section is preparing the team. So who's going to be the first intubator? Great. Second intubator?
Yeah, me.
And you're doing inline? Great. And monitoring and drugs, Chris. And then Bridget, you're our third nurse. Brilliant. Thanks very much. Okay, so we've gone through the checklist. Is everybody happy to proceed?
Yes.
Okay, lovely. Right, over to you for drugs then, Chris.
Okay, we'll start with fentanyl. Fentanyl going in. And flushed. Ketamine going in. And flushed. And rocuronium going in. And flushed. And timer started.
Okay, that's 45 seconds. Let's have a look. Thank you, Gavin. Okay, so I've got a grade 1 view. Bougie, thank you. So that's Bougie through the cords. ET tube, please.
Okay, I've got a bougie.
Thank you. Tube in. There we go, through the cords. So bougie out, please.
Bougie out.
Okay, can we inflate the cuff, please?
Okay, cuff up.
Okay, we've got chest rising, we've got misting, end-tidal CO2. Can you have a listen to the chest, please?
Okay, good breath sounds. Good breath sounds. Yeah, good breath sounds bad actually.
Thank you.
Following the initial assessment and intervention phase, a recap of the clinical situation and summary of findings is performed with the team. At this point, a decision is made on the next phase of care. We need to consider whether they are so unstable that we should take them straight to the operating theatre for damage control surgery. If they have been stabilised, we need to decide if they are likely to need emergency surgery but have time for imaging on the way to the operating theatre, or whether they may be able to go to a ward after imaging. The command decision should be brief and led by the team leader. Then the decision should be clearly communicated to the whole team and to the parents or guardians.
Okay, so we're in our huddle now after the patient's been intubated, so that will give us a chance to reassess him and decide what we do next. So we'll use our C, A, B, C, D, E approach again. So if we just go through those, catastrophic hemorrhage, I think we've agreed there's no evidence of that at the moment. Good, yeah. Okay, so A for airway.
We're happy with airway, he's intubated, we're in, the ET tube is secure.
Okay, great, and how about B?
So he's ventilating easily, his SATs have improved.
Okay, great.
There's no evidence of respiratory problems at the moment.
Brilliant. And C, you happy with C, Abby?
Yeah, his blood pressure's come up and his heart rate's come down, so I think C's fine at the moment.
Okay, great. And D, he's sedated at the moment.
He's sedated, morphine, midazolam, rocuronium, he seems stable.
Okay, fine. So I think we're all in agreement then that he's stable enough to go to CT. So let's get prepared for that.
To learn more about the management of paediatric trauma and to organise or take part in a paediatric trauma resuscitation course, please contact us on Twitter, via email, or take a look at our website.